Magnesium, $mg carat 2 plus $. The essential divalent cation, stands as a cornerstone of cellular biochemistry, often described as nature's functional counterpart to calcium. Its ubiquitous presence is reflected by its designation as the fourth most abundant mineral in the body and the second most abundant intracellular cation, surpassed only by potassium. Magnesium is intrinsically involved in modulating over 600 enzymatic reactions, dictating processes ranging from the foundational stability of genetic material to the complex dynamics of transmembrane ion transport and cellular signaling. While its importance is universal, the role of magnesium becomes profoundly critical and precarious in the context of human aging. Chronic, subclinical hypomagnesemia, characterized by low intracellular $mg carat 2 plus $ concentrations despite potentially normal serum levels, is a prevalent and often overlooked physiological imbalance in the geriatric population, acting as a silent saboteur that fundamentally undermines health, manifesting most commonly as debilitating chronic fatigue and painful, involuntary muscle cramps. To fully grasp the magnitude of magnesium deficiency in aging, one must first appreciate its centrality in cellular bioenergetics. Every instance of energy utilization in the cell is tethered to this mineral. Adenosine triphosphate, $ADP, the universal energy currency, must exist as a complex with magnesium, $mgdp, to be biologically active. Magnesium acts as a necessary cofactor for all enzymes involved in the hydrolysis of $ADP, including the crucial $Na carat plus /K carat plus $AT pump, responsible for maintaining osmotic and electrical gradients across cell membranes, a process that consumes a significant portion of the body's energy expenditure. In the mitochondria, the cell's energy factories, magnesium is vital for maintaining the structural integrity of the inner membrane and modulating the activity of key enzymes in the tricarboxylic acid $TC cycle in the electron transport chain $ETC. Specifically, deficiencies impair the functionality of cytochrome C oxidase and the F_0F_1 synthase complex, directly reducing the yield and efficiency of oxidative phosphorylation. In the aging process, which is already characterized by accumulating mitochondrial DNA damage and reduced mitochondrial biogenesis, magnesium depletion represents a compounding stressor, further compromising the cell's capacity to meet its energetic demands. This resultant state of chronic bioenergetic insufficiency translates directly into the pervasive and refractory fatigue commonly reported by older adults, a symptom often dismissed as an inevitable consequence of increasing years rather than a reversible mineral deficit. The relationship between mitochondrial dysfunction, reduced $ADP output, and physical exhaustion forms the primary scientific hypothesis linking hypomagnesemia to geriatric fatigue. Furthermore, magnesium is intrinsically linked to insulin signaling and glucose homeostasis, processes that profoundly influence energy balance and muscle function. $mg carat 2 plus $ is essential for the phosphorylation of the insulin receptor substrates and the subsequent signal cascade that facilitates glucose uptake into muscle and fat cells. Chronic magnesium deficiency impairs tyrosine kinase activity, leading to reduced insulin sensitivity and the development of insulin resistance. In the elderly, where type 2 diabetes mellitus, T2DM, is highly prevalent, this mineral deficit creates a detrimental feedback loop. T2DM itself promotes magnesium loss via osmotic diuresis, while low magnesium exacerbates the underlying insulin resistance. This compromised cellular glucose utilization directly contributes to cellular energy deprivation and chronic fatigue. Moreover, the increased systemic inflammation and oxidative stress associated with poorly controlled glucose metabolism are amplified by low magnesium, which normally acts as an effective anti-inflammatory agent by stabilizing membranes and inhibiting the activity of pro-inflammatory cytokines like tumor necrosis factor alpha, $10F-alpha, and interleukin-6, $IL, $6. The role of magnesium in neuromuscular excitability provides the clearest mechanistic link to muscle cramping. Magnesium acts as a physiological calcium channel blocker, regulating the flow of Ca2+ across excitable membranes. In peripheral nerves and muscle fibers, Mg2+ competes with Ca2+ at membrane binding sites and stabilizes the cell membrane, effectively elevating the threshold for depolarization. This stabilizing influence prevents the spontaneous, uncontrolled firing of motor neurons. When extracellular or intracellular Mg2+ levels drop, the balance is tipped. The reduced inhibitory control allows for an unchecked influx of Ca2+ into the myoplasm. Elevated intracellular Ca2+ is the direct trigger for muscle contraction. Its sustained presence, due to inadequate Mg2+ dependent relaxation mechanisms, specifically the failure of Mg-ADP to drive calcium back into the sarcoplasmic reticulum, leads to prolonged, involuntary, painful spasms. The characteristic nocturnal timing of these cramps may be related to subtle shifts in plasma volume and electrolyte concentrations that occur during sleep, coupled with reduced peripheral circulation or a lack of passive stretching. This profound shift in the calcium-magnesium ratio at the neuromuscular junction is the fundamental electrophysiological basis for hypomagnesemia-induced tetany and cramps. The heightened vulnerability of the older population to this deficiency stems from a trifecta of age-related physiological alterations. Firstly, gastrointestinal changes. Aging is associated with diminished gastric acid production, hypochlorhydria, which reduces the solubility of magnesium salts, impairing passive absorption in the small intestine. Furthermore, the active transport mechanisms for magnesium can become less efficient over time. Secondly, renal senescence. The inevitable decline in glomerular filtration rate, $GFR, and reduced renal tubule function, even without overt kidney disease, alters magnesium homeostasis. While the kidneys typically conserve magnesium efficiently, subtle tubular defects or chronic fluid imbalances common in the elderly can lead to increased fractional excretion of the mineral. This chronic renal wasting is often exacerbated by common geriatric pharmaceuticals. Thirdly, dietary insufficiency. Nutritional surveys consistently show that a significant percentage of older adults fail to meet the RDA for magnesium. This is driven by reduced overall caloric intake, decreased dietary diversity, less consumption of whole grains and green vegetables, and dental or swallowing issues that preclude the consumption of hard, magnesium-rich foods like nuts. In conclusion of the first section, the aging process inherently introduces several compounding risk factors: reduced absorption, increased renal loss, and insufficient dietary intake that converge to precipitate a state of chronic magnesium depletion. This deficiency, in turn, cascades into profound cellular dysfunctions, particularly compromising $ADP generation and deregulating neuromuscular excitability. Recognizing magnesium deficiency as a primary, rather than secondary, cause of fatigue and muscle cramps in seniors is the essential first step toward targeted, effective clinical intervention and improvement in geriatric health outcomes. The clinical presentation of chronic magnesium deficiency in the elderly is deceptively subtle, often leading to a significant diagnostic delay or misdiagnosis. The cardinal symptoms, chronic fatigue and persistent, often nocturnal, muscle cramps, are so common in this demographic that they are frequently attributed to advanced age, musculoskeletal degeneration, or polypharmacy side effects without an investigation into the underlying electrolyte disturbance. To effectively manage geriatric health, clinicians must maintain a high index of suspicion, understanding that these symptoms represent direct biophysical consequences of compromised magnesium status. The link between chronic fatigue and subclinical hypomagnesemia extends deeply into the neuroendocrine and immunological systems. Beyond the bioenergetic failure discussed in Part 1, magnesium acts as a vital neuroregulator. It modulates the activity of the $HP axis, which governs the body's stress response. Low magnesium levels are associated with increased excitability of the $HP axis, leading to chronic elevation of cortisol and other stress hormones. Sustained high cortisol levels contribute to central fatigue by disrupting sleep patterns, promoting muscle catabolism, and fostering a state of sympathetic nervous system hyperarousal, preventing adequate rest and recovery. Furthermore, magnesium plays a key role in the synthesis and metabolism of several critical neurotransmitters, including serotonin, which influences mood and sleep architecture, and dopamine, which regulates motivation and energy drive. Deficiency can thus contribute to symptoms of apathy, low mood, and diminished vitality, which are often inseparable from physical fatigue in the clinical setting. The concept of inflammaging, or the chronic low-grade, sterile inflammation that accompanies aging, is also exacerbated by magnesium deficit. Magnesium is a natural calcium channel blocker, and its depletion allows for excessive $2+ influx into immune cells, activating the NF-kappa B pathway, and promoting the release of pro-inflammatory cytokines, such as tumor necrosis factor alpha, TNF-alpha, and interleukin-6, IL-6. This chronic inflammatory state is intrinsically linked to persistent central and peripheral fatigue. The pathophysiology of nocturnal leg cramps is intricately tied to magnesium's role as an electrical stabilizer. The reduced inhibition at the neuromuscular junction due to low magnesium manifests as increased motor unit activity, leading to fasciculations and eventually the painful, sustained contraction characteristic of a cramp. This effect is compounded in the elderly by age-related sarcopenia and reduced circulation. Sarcopenia, the loss of muscle mass and function, inherently makes the remaining muscle fibers more vulnerable to overexcitation and exhaustion. Reduced peripheral circulation, particularly during sustained periods of rest at night, can lead to localized hypoxia and accumulation of metabolic byproducts, which further irritate nerve endings and lower the threshold for spontaneous firing, a phenomenon that is poorly controlled when magnesium, the primary stabilizer, is deficient. Research has consistently demonstrated that magnesium supplementation can significantly reduce the frequency and intensity of nocturnal leg cramps, providing compelling clinical evidence for its causative role. A major impediment to routine diagnosis is the inherent limitation of standard serum magnesium testing. Serum $mg 2+ accounts for less than $1% of total body stores and is tightly regulated by homeostatic mechanisms. When intake is low, the body aggressively maintains serum levels by mobilizing magnesium from its primary reservoir, bone. Consequently, a patient can be severely depleted at the cellular and tissue level, leading to symptoms, while maintaining a seemingly normal serum concentration. This regulatory mechanism means that by the time serum hypomagnesemia is confirmed, the total body deficit is already substantial. Clinicians should advocate for or consider more accurate, though less conventional, diagnostic tools. Red blood cell magnesium, $RBC\text, mg. Levels often reflect long-term intracellular status more accurately than serum levels. A magnesium loading or retention test, where the patient's urinary excretion is measured after a controlled intravenous infusion of magnesium, is considered the gold standard for assessing total body deficits, revealing significant retention, low excretion, in deficient individuals. While time-consuming, these tools offer objective evidence to support clinical suspicion based on symptoms and risk factors. The prevalence of chronic diseases in the elderly creates a complex tapestry of comorbid factors that profoundly exacerbate magnesium depletion. Type 2 diabetes mellitus, T2DM. This condition is one of the most significant risk factors. Chronic hyperglycemia leads to osmotic diuresis, meaning the increased fluid flow through the renal tubules washes out magnesium, resulting in persistent urinary wasting. Furthermore, the accompanying insulin resistance diminishes magnesium-dependent glucose transport into cells, leading to a vicious cycle where magnesium deficiency contributes to poor glycemic control, and poor glycemic control causes further magnesium loss. Cardiovascular disease, CVD, and hypertension. Magnesium is a critical factor in cardiac health, acting as an antiarrhythmic and vasodilator. Deficiency contributes to hypertension by allowing uncontrolled vascular smooth muscle contraction due to unchecked $CA-2+, and promotes endothelial dysfunction. More importantly, the management of CVD frequently involves medications such as loop and thiazide diuretics, which are notorious for causing renal magnesium wasting. Thus, the very treatments intended to manage heart failure or hypertension are often silently contributing to muscle cramps and fatigue. Chronic kidney disease, CKD, although severe CKD can lead to hypomagnesemia due to impaired excretion. Early and mild to moderate CKD, often co-occurring with T2DM and hypertension, can actually be associated with subtle renal tubular dysfunction that promotes magnesium wasting, highlighting the nuanced relationship between renal function and magnesium balance in the geriatric patient. The ubiquitous use of pharmaceuticals in the elderly, polypharmacy, is perhaps the most modifiable yet most frequently overlooked contributing factor. Beyond diuretics, proton pump inhibitors (PPIs), like omeprazole and lansoprazole, widely prescribed for $Gerity, drastically reduce magnesium absorption by inhibiting the necessary acidic environment for the mineral's solubility and transport. Long-term $PPI use has been definitively linked to severe hypomagnesemia requiring hospitalization. Other culprits include certain antifungal agents, chemotherapeutic drugs, e.g. cisplatin, and immunosuppressants, e.g. cyclosporin, all of which can increase renal tubular damage and subsequent magnesium loss. A meticulous review of the patient's medication list is therefore not merely an ancillary step, but a core component of the diagnostic process for chronic fatigue and cramps in the elderly. In essence, the clinical landscape of magnesium deficiency in the senior population is characterized by nonspecific symptoms driven by profound bioenergetic and neuromuscular instability, compounded by age-related physiological decline and complex pharmacological regimens. Recognizing fatigue and cramps not as isolated symptoms, but as potential indicators of systemic magnesium depletion is crucial for transforming palliative care into curative intervention, directly addressing the mineral deficit at the root of the patient's distress. The therapeutic approach to chronic magnesium deficiency in the elderly demands a paradigm shift from simple symptomatic relief to comprehensive mineral restoration. Given the cumulative burden of reduced intake, poor absorption, and pharmaceutical-induced wasting that characterizes aging, merely recommending minor dietary adjustments is often insufficient. An integrated solution requires meticulous attention to dietary quality, informed selection and dosing of supplements, and a systematic reconciliation of potentially harmful medications. The ultimate goal is to restore optimal intracellular $2+ levels to alleviate chronic fatigue and eliminate debilitating muscle cramps, thereby dramatically enhancing the quality of life and functional longevity of older adults. The initial, non-pharmacological strategy must center on dietary optimization. Dietary sources of magnesium are abundant, yet their bioavailability and consistent consumption often pose challenges for older adults. The recommended dietary allowance, RDA, for magnesium is typically around $420 mg per day for men and $320 mg per day for women over the age of 51, though individual needs may vary based on comorbidities and medication use. Key food sources include dark leafy green vegetables, e.g. spinach, kale, nuts and seeds, e.g. almonds, pumpkin seeds, chia seeds, legumes, whole grains, e.g. brown rice, oats, and dark chocolate. Given the reduced caloric intake and often limited digestive capacity in the elderly, emphasizing nutrient-dense, magnesium-rich foods that are easily digestible is crucial. For instance, incorporating seed and nut butters, fortified cereals, and regular servings of legumes can significantly improve overall magnesium intake. Practical dietary strategies. Given common issues in the elderly, such as dysphagia, reduced appetite, and dental problems, emphasizing soft, magnesium-rich foods is essential. This includes 1. Magnesium-rich powdered ingredients. Incorporating unsweetened cocoa powder, hemp seeds, or finely ground flax seeds into soft foods like yogurts, smoothies, or oatmeal. Soaking and sprouting. Soaking nuts and legumes reduces phytate content, which are compounds that chelate minerals and inhibit magnesium absorption. This simple preparation method enhances bioavailability. Green smoothies. Blending dark leafy greens, like spinach and kale, into smoothies circumvents the need for extensive chewing while preserving the high magnesium content. Furthermore, attention must be paid to micronutrient synergy. Magnesium absorption is highly dependent on sufficient levels of vitamin D. Calciferol, vitamin D, increases intestinal magnesium absorption by stimulating the synthesis of $mg 2+ transport proteins. Many older adults are deficient in vitamin D, creating a compound deficiency that severely limits the effectiveness of dietary magnesium. Therefore, assessing and correcting vitamin D status is often a necessary precursor to successful magnesium repletion therapy. Conversely, high doses of zinc, iron, or calcium supplements can compete with magnesium for absorption sites, necessitating careful timing of administration to avoid antagonistic interactions. When dietary modifications prove insufficient, a common scenario given age-related malabsorption and pharmaceutical interference, magnesium supplementation becomes a necessary intervention. The selection of the appropriate magnesium compound is critical, as bioavailability varies significantly. Magnesium oxide, while containing a high percentage of elemental magnesium, exhibits poor intestinal absorption and is often used for its laxative effects rather than for correcting systemic deficiency. More bioavailable forms are preferred for therapeutic supplementation. Advanced supplementation protocols, bioavailability, and dosing. The choice of magnesium salt is paramount, moving past the common, low bioavailability forms like magnesium oxide. The primary criterion for therapeutic efficacy is the salt's water solubility and low molecular weight, which dictate its absorption rate and subsequent utilization. Magnesium glycinate. This is arguably the most preferred form for chronic correction in the elderly. It is formed by chelating magnesium with the amino acid glycine. This chelation protects the magnesium from competitive absorption in the gut and provides superior bioavailability with minimal gastrointestinal side effects, e.g., diarrhea, compared to salts like oxide or high-dose citrate. The co-administered glycine also has neuroinhibitory properties, potentially aiding in muscle relaxation and improving sleep quality, indirectly addressing the nocturnal cramping issue. Magnesium L-threonate. While often marketed for its nootropic, cognitive-enhancing properties due to its reported ability to cross the blood-brain barrier, $. Its excellent systemic absorption makes it a viable candidate for general repletion. For older adults experiencing fatigue compounded by brain fog or cognitive decline, this form offers a dual therapeutic benefit, although its cost is typically higher. Magnesium malate, chelated with malic acid. This form is well absorbed and often recommended for patients experiencing chronic musculoskeletal pain and fatigue, as malate is an intermediate in the $TC cycle and may contribute to enhanced energy production, offering a direct physiological boost in line with the therapeutic goals. Dosing and administration strategy. The therapeutic dose for correcting chronic subclinical deficiency generally ranges from $400/text mg to $600/text mg of elemental magnesium per day, often exceeding the standard RDA. This higher range is often required to overcome absorption inefficiency and high urinary losses. A critical strategy is divided dosing, taking the total daily dose in 2 or 3 smaller increments, e.g., morning and evening, significantly improves absorption efficiency and minimizes the risk of osmotic diarrhea. For specific targeting of nocturnal leg cramps, The largest portion of the dose should be administered approximately 1 hour before bedtime. Crucially, supplementation must be managed with caution and monitored by a physician, particularly in patients with pre-existing renal impairment, as the kidneys are responsible for excretion and excessive accumulation. Hypomagnesemia can lead to serious cardiovascular and neuromuscular complications. Clinical management and monitoring. Effective magnesium therapy in the geriatric population requires vigilant clinical management to ensure safety and efficacy, especially concerning renal function and polypharmacy. The polypharmacy audit. Every older patient presenting with chronic fatigue and muscle cramps must undergo a meticulous pharmacological audit. Clinicians must identify and systematically attempt to discontinue or substitute known magnesium-wasting medications, particularly $PPIs and thiazide/loop diuretics. If discontinuation is impossible, e.g., essential diuretic use for heart failure, the patient must be placed on mandatory, supervised supplementation to proactively mitigate drug-induced depletion. This strategy transforms the management of the side effect from reactive to proactive. Monitoring in renal impairment. Given the age-related decline in $GFR, monitoring is non-negotiable. Serum creatinine and estimated $GFR must be established before initiating high-dose supplementation. In cases of significant renal impairment, $GFR less than 30\text, /\text, min $, magnesium excretion is compromised, and there is a genuine risk of hypermagnesemia, which can lead to severe symptoms including muscle weakness, hypotension, and cardiac arrest. Supplementation in these patients must be approached cautiously, using lower doses and requiring periodic monitoring of serum magnesium levels to maintain them safely within the therapeutic range, typically $1, 7\text to 2, 5\text mg/\text $. Advanced diagnostic follow-up. Relying solely on symptomatic improvement is insufficient. For scientific rigor and optimal patient care, advanced diagnostic testing is highly recommended. Repeating the $RBC\text mg test or $8.24 hour urine $2+ test after 3 to 6 months of targeted supplementation provides objective evidence of tissue repletion, confirming that the intervention has been successful in correcting the fundamental deficit rather than simply masking symptoms. Conclusion and future directions. The chronic insidious depletion of magnesium is increasingly recognized as a major, yet highly treatable, contributor to the burden of chronic fatigue and musculoskeletal dysfunction in the elderly. The scientific evidence points toward compromised bioenergetic efficiency and deregulated neuromuscular control as the direct mechanistic links. By applying an integrated approach that prioritizes dietary enhancement, strategically selects high bioavailability supplements, such as glycinate or malate, systematically addresses drug-induced depletion, and rigorously monitors patients, particularly those with renal compromise, clinicians can achieve profound improvements in geriatric health outcomes. Future research must continue to focus on developing highly specific non-invasive biomarkers for intracellular magnesium status and establishing formalized clinical practice guidelines for magnesium repletion in the context of chronic polypharmacy. Ultimately, recognizing and aggressively treating the silent saboteur of magnesium deficiency represents one of the most cost-effective and impactful strategies available today for promoting vigorous and independent aging.